Yes, start now.
Yes.
8 o'clock.
Good evening, everyone. We extend a heartfelt welcome to all of you joining here. So, this is a month long webinar series hosted by Endocrine Society of India on the context of World Hormone Day, which is going to be celebrated on 24th of April 2026. So, we have all the stalwarts of endocrinology and India who will be actually talking on the various aspects of the hormone. So, we call it the hormone insights, and then all of the stalwarts present their point of views or the learnings of their life with all of us and enlighten us with their knowledge. So this is the first session of Hormone Insights, and here with us, the chair being Dr. Kaushik Pandit sir, who is the Endocrine Society of India president, and we have the current moderator of the session, Dr. Kaushik Biswas, who will be moderating the session. The speakers are Dr. Anil Bansali sir, who needs no introduction, and but of course our very own Dr. Shubhankar Chaudhary sir, again who is again a very big teacher by himself. So just I'll take a couple of time for all of us to just see a small video trying to understand about what we are trying to do on this. And this is basically a World Hormone Day, a logo which we are trying to unveil here for the first time for all of you trying to understand this. Yeah, this is our logo, World Hormone Day logo, which talks about the hormones, the balance, and the health. All in all, what we want to communicate or what we want to re-emphasize is that maintaining your hormones or hormone health leads to a better health outcome and all of the related quality of life. And with this, the next part of the show would be like I would like to invite Dr. Kaushik Pandit sir, who is our President, Endocrine Society of India, to address the gathering. Sir.
Good evening, everybody who have joined. World Hormone Day is one great occasion to focus on the relevance and the importance of endocrinology for clinicians and laypersons alike. Endocrine Society of India is proud to celebrate this World Hormone Day on 24th of April 2026. And we have started this journey today and kickstarting this relevant campaign today with stalwarts in endocrinology presenting their views on endocrinology. They are the most renowned names in India, and it is our proud privilege that they have agreed to share their views on this platform. And Endocrine Society of India is proud to host this very important occasion of World Hormone Day starting from today. So I am very happy to invite all of you and welcome and hope that you will enjoy this presentation. Thank you very much.
Thank you, sir. Now, I would like to invite our moderator of the session, the young dynamic Dr. Kaushik Biswas, who hails from Kolkata. Again, a very young clinician, I would rather tell. I call him Dada by my fond memories and fond relations with him. Dada, over to you. You host the show.
Thank you. Thank you, Basam. So, good evening and a very warm welcome to all. It's my distinct privilege to welcome two legendary endocrinologists, Professor Anil Kumar Bhansali and Professor Shubhankar Chaudhary, in this webinar. Their presence today is a true honor for us, and we look forward to an enlightening and inspiring session. So first talk will be given by Professor Anil Kumar Bhansali. Sir is needed no introduction. Basically, he is currently the director of Genie Health Mohali. Sir headed the Department of Endocrinology, IPG, PGIMR, Chandigarh for a long time, and he was the past president of Endocrine Society of India. He has multiple accolades in his career. He published hundreds of original articles as well as books. So I request Professor Bhansali sir to take the platform. Sir.
Thank you, Chairperson. At the outset, I am thankful to the Endocrine Society of India for inviting me for this inaugural speech on hormone disorders. So this is I think it's my privilege and I feel honored that being a part of it. I always enjoyed the society. I was the president of society way back in 2012, 2013. And this invitation against reminds us that we are all alive and we are all one. So I think before we just say, because this was a World Hormone Day, and we just had a discussion that how this came on 24th of April. This was the first hormone which came was a secreted by the Starling and Bayliss. So that's why, and that was the day was the 24th of April. So that's why the day is celebrated as the World Hormone Day. And I'm also talking about the hormones and longevity. So life is a hormone and hormones are life. So I think that's a motto what we see in the life. So before I start my presentation, I am also thankful to my colleague, Mr. Gurjot Narwal, for very immensely contributing in preparing my slides. So now I'll show my slides. Share. Share screen. Visible now?
Yes, sir. Yes, sir.
Yes.
Yeah.
Yes, sir.
Perfect.
So I'll be talking about the hormones and longevity from biology to bedside. What hormones tells us about how we age. So this is my presentation overview. So I'll be just covering on the different aspects of this. The whole world is aging, and it's in fact very rapidly. If you see the Japan, there almost 30% of the people are above the age of 65 years. In US, the figure is around 18%. In China, something around 15%, while in India, the figure is around 7%. So only 7% of the people are able to cross the age of 65 in our country. But it also means that our population base is pyramid base is quite wider. So we have a lesser number of the people, those who are approaching near 65, as well as our life expectancy is also low. So that's why our number of the people above the age of 65 years is only 7%. However, within the next 10 years, it is going to be double. If you see the global life expectancy gap, the women, they live slightly longer, around 4 to 5 years, roughly around 74 years, while the man is something around 68 years. We always discuss living longer because the people ask why I should live longer, but I should live more healthy. So I think we now define by the living longer versus living better. The living longer means it's a lifespan, the total number of years lived, and that simply means the chronological age what you achieve till your demise. The health span means how many years you live without any significant comorbidities. And WHA now defines as a healthy life expectancy that is called HALE. And India's HALE is around 10 years lesser than the health span. So in India, the diseases, in fact, the people in India, they do have a disease which occurs earlier. The disease is more intense, it's more severe. So the lifespan and the disease and the health span, in fact, they don't match. But possibly, with the improvement in clinical care, with the improvement in the facilities available or infrastructure available for the medical health, the gap between the health span and a lifespan will also reduce. So almost we have got a 10 years difference between health span and lifespan. So even you may not live longer, but you are living healthy. That's a more achievement rather than living longer. So if you see that why we should live longer, in an animal kingdom, every organ, in fact, every animal has got it's a genetically programmed to live for a certain age. If you see the rat, it's around 6 months. If you see the dog, it's around 15 years. If you see the naked mole rat, it's a 30 years. And I will tell you the interesting aspect of a naked mole rat is they are devoid of the insulin, IGF-1 signaling, and that is now GH has been said to be the only hormone which is associated with improved aging. So GH deficiency leads to increased survival or increased age as opposed to any other hormone, which we'll also discuss in detail in our presentation. The elephant has got around 70 years of lifespan. The human, the average, we are living now 73 years in the current era. However, theoretically, we have got anecdotal evidences. Even a Lord Krishna was 125 years when he died, and at least he was 90 years when the Mahabharata war was fought. Similarly, Bhishma Pitamaha was also around 120 years, and when he fought the war, he was also around 90 years. And turtle has got something around 100 years of life. So every animal has got a genetically programmed and to live longer. So this is called as a biological destiny, which is possibly more genetically determined. But definitely this is modifiable with the lifestyle modification programs. Just the sorry for that. The biology of aging, what happens inside cell and tissues as we age. So these are the 12 hallmarks of aging, and as we age, all parameters in fact become in action, and they are basically starting from the. That's why if I remember at our cremation ground at my place, there was one line which was mentioned, which I could never understand till few years earlier, is that the death starts soon after birth. So means that the whole process of aging starts from day one of the life, and you can see that the decreased vascularity has been proposed as one of the very principal mechanisms. As we grow older, the vascularity for each organ is reduced. There are hormonal pauses which you have. Some are protective, some are adaptive, and some are really maybe detrimental. You have a genomic instability with aging. You have a telomere attrition, epigenetic alterations, loss of proteostasis, disabled autophagy, mitochondrial dysfunction, cellular senescence, stem cell exhaustion with time, and altered cell communication and chronic inflammation. So these are the 12 hallmarks of aging which have been comprehensively reviewed in the literature, and possibly all these processes, they go in a very integrated way and eventually lead to cell senescence and cell death. So whether the hormones, now we'll talk about the hormones because it's a hormones day. Hormones are markers, they are mediators, or they are medicines. They are markers because the low hormone level, this is just as an epiphysiology. As you age, the hormones decreases with age, whether it is a estrogen, whether it is a testosterone, or whether it is a GH, or whether it is a DHES. So these are just epiphenomena with aging. They are mediators. The hormones decline directly drives specific pathological changes, like estrogen after menopause directly causes bone loss, hot flashes, and vasomotor symptoms. They may be the medicine. If you replace, you possibly improve the quality of life. You possibly improve the muscle mass, bone health, and many other things which may contribute to increase in lifespan or increase healthy lifespan, what we used to talk. So the hormonal pauses, we all know about the four parallel hormone decline stages. They are andropause, somatopause, menopause, and adrenopause. In adrenopause, we are mainly concerned with the DHEA, which falls around 80% by the age of 70 years. If we see the GH-IGF-1 somatopause, GH-IGF-1 paradox at the heart of longevity. This is the one of the very adaptive mechanism on a physiological basis, which is basically meant for preventing the or extending the lifespan. If you see that what somatopause causes, the GH falls around 14% per decade from age 30. With the GH deficiency is associated with increase in visceral adiposity, there is a decrease in lean muscle mass and bone density, there is impaired recovery and healing, and there is a cognitive fatigue. The longevity paradox. If you see that dwarf mice who are GS deficient, they are having a longer lifespan as opposed to the other mice. Second, Laren syndrome, they do have an IGF-1 resistance. They also have a no malignancy and preserved cognition. The smaller dog breeds, they have a low IGF-1, they live long. So this is the paradox. If you are growth hormone deficient, or if someone is growth hormone deficient, it's as a part of the somatopause. Possibly it is a more adaptive phenomena and may contribute to the longevity. But if you're deficient, then certainly you do have a problem of visceral adiposity, you have a decrease in lean muscle mass and bone density, and impaired insulin action. As far as the andropause is concerned, you have got a decrease in testosterone almost 1% per year after being 40. SSBG rises with age around 1.2% per year. The DHEs goes 80% by the age of 70. The clinical features mostly are non-invasive, but overall, you have a mainly sarcopenia and bone density, and you have a fatigue, low libido, and erectile dysfunction. And when you have a confirmed deficiency of the testosterone, you treat it. The treatment helps in improvement in sexual function, energy levels, muscle mass, bone density, but we don't have such data that it increases longevity. It definitely improves the quality of life, and possibly, so healthy lifespan increases with androgen replacement therapy in androgen deficient men. As far as the menopause is concerned, the ovary is the earliest age. Something around the nature aging. The ovary is the first tissue to undergo profound age-related functional decline. And consequences of estradiol loss leads to bone loss, increase in cardiovascular risk, early menopause, the genitourinary syndrome of menopause, and cognitive changes. The menopausal hormone treatment, now called as MST rather than HRT, and if you can do that, the first line for a vaginal symptom, if started early means something around at the age of soon after menopause and maybe continued for a period of next 10 years rather than after the age of 65. The CAD and diabetes goes down, not for dementia prevention, not for general anti-aging. So again, you see that the healthy lifespan is increased even with the estrogen supplementation, but may not increase the longevity in that terms. The other key hormones in aging, which is of interest to everyone, particularly insulin IGF. Insulin is basically a hormone. If in an insulin sensitive state, it's vasoprotective. It improves vascularity, it improves endothelial function, it decreases inflammation, it's a vasodilator. So many qualities of insulin on vasculature. And as I mentioned earlier, one of the leading cause of aging of the different organs is decreasing vascularity. In an insulin-resistant state, the vascularity is remarkably decreased, and that's why we say that the long-term consequences of insulin resistance, and you have a evolution of the constellation of metabolic abnormalities, which eventually lead to cell senescence and death. So I think insulin itself is good, but insulin resistance and consequent hyperinsulinemia is vascular detriment or vascular. It produces vascular injury and leads to progressive decline in vascularity to the different organs of the body. If you see the insulin IGF-1 signaling pathway, the many C. elegans, fruit flies, mice, dogs, even humans. The lower IGF-1 has got a better insulin sensitivity, least anti-proliferative effect, lesser probabilities of malignancy in old age. So I think most of the things are related to insulin. So insulin has got a manifold action, partly through IGF-1, partly a direct effect on vasculature, partly direct effect on lipids. So all may be contributing for vascular damage. So why reduced insulin sensitivity promotes longevity? That you have an increase in FOXO transcription, you have an increase in autophagy, decrease in mTOR signaling, decrease in oxidative DNA damage, and decrease in cancer risk. So if you have a decrease in insulin IGF-1 sensitivity, it promotes longevity. So keeping the free from insulin resistance or keeping free from hyperinsulinemia means, in other words, if you're promoting, if you are maintaining your lean muscle mass and reducing your body fat or keeping your waist in a baseline schedule, then it is very, very likely to be having a better protective effect of hyperinsulinemia. And therefore, the role of the GLP-1, we will also talk about that, that play also may role in increasing the longevity. A word about the cortisol, because the cortisol is one of the hormones which usually does not change with age, except that with age, there is a loss of circadian rhythm. And this leads to greater exposure in the evening hours, to may contribute to cell adiposity, decrease in muscle mass, increase in muscle fat, and decrease, and even the hippocampal loss. So your memory and cognitive function will go, and immunology. And the chronic stress accelerates telomere shortening by more than 10 years. A circadian aging, the melatonin also falls with age. There is a disrupted sleep, decrease in nocturnal G pulse. In addition, the circadian alignment and immediate consistent sleep wave. So your circadian aging also happens with age, and that is also. And a word about the oxytocin, which supports not only the family bonding and love and affection, but also has got an effect on muscles, also has got an effect on, also has got an effect, also has got an effect on blood products. So you heard so many beneficial effects of these hormones in setting with the aging. A word about adipose tissue and so if you talk about the adipose tissue as an endocrine organ, the aging adipose tissue, they leads to more production of adipokines, which are really harmful. It increases the senescent size. It leads to chronic low-grade inflammation and altered adipokines. And as you grow with the age, you always have a more fat. The adipose tissue mass increases with age, and this increase in adipose tissue mass further contributes to aging. The remodels with age even without weight change. So it impairs insulin sensitivity body. It secretes IL-6 and TNF-alpha. It also leads to more contribution of the sarcopenic obesity because more fat accumulates into the muscle, and that whether it is a part of the intramyocyte or intramyocyte, and the fat in the muscle or white adipose tissue into the muscle leads to further exacerbation of sarcopenia, inflammation, and muscle balance. As you lose the fat from the muscle is reduced. All sex steroids and GH protect against small adiptive adipose removal. As far as thyroid is concerned, remember that the rising TSH is a part of the aging phenomenon, and this is possibly because of the age-related decrease in T4 to T3 conversion in hypothalamus, and possibly the T3 resistance to suppression of TSH with aging. And the rising TSH, if you try to make the TSH normal or low normal, even in the aging population, it leads to progressive decline in cognitive. So remember that it's all an adaptive phenomenon, and adaptive phenomena should not be altered unless there are some benefits regarding the quality of life improvement, as we see in androgen replacement therapy as possible in menopausal hormone treatment. A word about the hormones and telomeres. The telomeres are the one of important parameter or important index for aging. You have the effect of estrogen, it stimulates telomerase activity. Insulin resistance shortens the telomere length. That's why and obesity is also associated with increasing telomere length. And even people have shown after bariatric surgery, there is an improvement in telomere length with the post-bariatric surgery. The testosterone also improves the telomere length. It increases muscle, decreases the adiposity in oxidative stress, and similarly, the optimal amount of IGF also helps in maintaining the telomere length. The cortisol axis leads to decreasing telomere length. A word about the endocrine disruptors. They also contribute in aging, and this includes plastics, pesticides, PFAs, the hidden hormones. So you have to for your hormones meet the environment, and you have so many things which is contributing for this. So people have in this all cardiovascular diseases, metabolic syndrome, premature menopause, thyroid disruption, fertility, testosterone, and even people talk about the fertility. So many things in our hormonal cycle can be altered by the endocrine disruptors. Interventions now and future. So we have a calorie restricted intervention. Insulin resistance is one of the important regulator of senescence. So we can say that insulin is the essence of life. So beta cell is the essence of life. Hyperinsulinemia in any way or insulin resistance in any way is detrimental for health. So improved insulin sensitivity by calorie restriction or by the time restricted eating may lead to decrease in insulin, IGF-1, mTOR inhibition, and there is a oxidative stress is also decreased. It will also lead to improvement in telomere protection. If you have a sleep optimization, then the nocturnal GH pulse requires deep sleep. And melatonin resets circadian axis that also improves sleep optimization. The stress management, decrease in cortisol, decrease in insulin resistance, and decrease in telomere depletion. The zone 2 aerobic exercises also contributes to more mitochondrial biogenesis, so they all improve the cellular processes. The resistance training, hormonal like testosterone, GH, they prevent sarcopenia and preserves movements. Near universe deficiency in India and hormonal like PTH is reduced, bone and muscle mass improves with vitamin D. A word about the hormone therapy, the menopausal hormone therapy or a testosterone replacement therapy or a growth hormone replacement in adults with growth hormone deficiency may contribute to, however, may not increase the lifespan, but may improve the healthy lifespan in people, those who are deficient. So pharmacology pipeline. So rapamycin as an mTOR inhibitor, it's the most robust lifespan extender across species in NIH interventions. Senolytics like dasatinib and quercetin, the selectively clear senescent zombie cells. It's a phase 2 trial is doing in frailty and pulmonary fibrosis. The NAD plus precursors NMN and NR, mitochondrial function restoration. Interleukin 11 inhibitors, the GLP-1 agonists, the multi-omic ACE counteracting effects in mice, not yet proven in humans. Oxytocin plus ALK5 inhibitors, you have about a 70% lifespan extension in elderly. So most of the data are real data, but they are very, very increasing. A Indian perspective, are we really more prone for aging faster? Possibly, yes. The sarcopenic obesity, vitamin D deficiency, fetal programming, that is what we call DOHAR. Endocrine because the birth weight is low, so as a part of the Barker hypothesis, endocrine disruptors. So, and currently we have only 7.1% or 7% people above the age of 65 years. Certainly, and we don't have those data, but certainly our phenotype and even our the vascular side is very small. People have shown that the coronary vasculature in people with Caucasian and people of Asian origin, it is almost 50% caliber is less as opposed to the Caucasian population. So the clinical take home, the 6 things to remember. The goal is health span, not the to preserve function, strength, cognition, and independence, not the hormone level of a 25 years old. So remember that our aim is not to keep the hormone of a 25-year-old like that by supraphysiologically replacing. As most of the people now in gym practice and all, they are taking a lot of hormones. It is not going to prolong the aging. So for a healthy aging, let these pauses should be an adaptive mechanism and only to be replaced if they are deficient. Then and then they will be helpful in keeping the healthy lifespan. Secondly, the hormonal declines drives and you have a lot of loss of estrogen and testosterone loss, especially sarcopenia and bone loss. So these are not the norm. They should be accepted if they are part of the disease process. Lifestyle is most important. Timing is everything. If you start menopause and hormone replacement therapy at 50, just at the menopause, rather than going up to 70, the window matters enormously. So timely replacement is also very important. And lifestyle is most robust. And now the precision longevity medicines. There are so many things which are going to come, like so many hormones will be available in the future, though they are still in pipeline. And India must act now for a sarcopenic obesity, fetal programming, vitamin D deficiency, premature hormonal decline, creates a uniquely Indian aging body. So I think all can be taken care of with time. Thank you. The question is no longer, but how long we live, as it is how well we live. Thank you. Thank you for your patience here.
Thank you. Thank you very much, sir, for your brilliant deliberation on the biological and hormonal domains of human existence and longevity. Currently, there is no question in the chat box, but at the end, we will take if there is any. So now I'll invite Professor Shubhankar Chaudhary to take the dais. Sir also needs no introduction. He was the head of the Department of IPGMR Kolkata for a long time. He is currently the director of Manipal Group of Hospitals, Department of Endocrinology. Sir has multiple publications, and most importantly, sir is the teacher of teachers. So, sir, over to you.
Thank you very much. It's a wonderful occasion to be with all of you. And my special greetings to, just let me get this slides. So my greetings to all our members, but especially to the younger generation, those in training. And I sincerely hope that whatever little that I shall talk about, will be a stimulus for people to go into greater depths, read up, and really arm themselves better to face their patients in real life. So what I have tried to do is, first of all, start from a relatively easy area of thyroid, and then maybe go on to, as time permits, whatever the time we'll have, we talk about Cushing's disease, and then go on to acromegaly. And this is about all that I wish to cover, if at all I have the time for it. So in relation to thyroid, I think we are all very happy be about management of hypothyroidism, but we all do agree that there are individuals who, despite being on apparently adequate doses of levothyroxine and even possibly uh, normal levels of hormone, they are not symptomatically fully happy. And there may be some role for adding T3 in those individuals. But what I wanted to bring to the light as to everyone's notice is that there is something called thyroid organoid, which is actually a three-dimensional tissue culture of thyroid, either from patients' own cells or from stem cells or from elsewhere, which has been used for studying thyroid-related issues, studying Graves' disease, having a model of the disease outside the body, model of the gland outside the body, including testing out anti-cancer drugs. But what this paper, the Nature paper in November 2022 showed that you can transplant human thyroid organoids generated from embryonic stem cells to rescue hypothyroidism. So whenever we start treatment for hypothyroidism, a common question that we get is, Doctor, how long are we going to take the medicine? Is it not going to give me side effects and so on? So here is a potential cure for hypothyroidism where you can transplant human thyroid organoids. Now, this particular study, however, was in mice, not in human beings, and was just a proof of concept. Maybe in future, we may have such a treatment for hypothyroidism as well. And then for hyperthyroidism, we have all been using the antithyroid medication, radiation, radioactive iodine, and surgery. But I am sure most of you would agree that definitive treatment leads you from one disease to another disease, hyperthyroidism to hypothyroidism. So it's not really a cure of hyperthyroidism in the true sense of the term. So in that respect, well, new developments include novel immunotherapies, anti-CD40 antibodies, and really a whole amount of work is also been done in small molecule CSH receptor antagonists. What we are using anti-thyroid drugs inside the thyroid cell to block the synthesis of thyroid hormone, but you can also have TSH receptor antagonists, and these are not antibodies, these are small molecule compounds. A number of them are in development phase. However, I must warn that none of these are anywhere near to coming to clinical use even in the next 5 years, or maybe even 10 years. And then there could be biomarker-driven strategies which will make those more destructive forms of treatment, radioactive iodine and surgery, less necessary. Quickly, we'll turn to maybe thyroid nodules, thyroid cancer. We will not dwell too much on them. Of course, we all know the advances in immunotherapies, PD-1 antibodies, and CTLA4 antibodies, and so on and so forth, targeted kinase inhibitors for advanced thyroid cancers. Fortunately, those are not very many, but they are there where we can now take recourse to these treatments. And there is the other part is development of precision diagnostics. So many thyroid nodules, for example, in the group of follicular neoplasm of the thyroid, we cannot confidently say whether it's a follicular adenoma or carcinoma. So better and better molecular profiling of thyroid nodules may help us to distinguish with certainty in this group. And we have had very good publications from Kolkata itself, from Dr. Sujal Ghosh's group, in relation to cell-free DNA being a help in this regard, which needs to be validated in more studies possibly. The other part exciting that's also happening is in relation to management of thyroid nodules now, which are non-malignant. So many of them would not merit sort of a destructive form of surgery. Minimally invasive ablation techniques like radiofrequency ablation, microwave ablation, laser thermal ablation may also be used more widely. These are available nowadays, but not yet quite standard of therapy. But these also may become available to be used for cases of thyroid nodule rather than just wait and watch and maybe for surgery when the tumor, the nodule grows too big. We can offer these minimally invasive ablation techniques. So this is all that I wanted to sort of quickly round up and talk about thyroid disorders. Now about Cushing's disease. Everyone who is a practicing endocrinologist knows the difficulties with Cushing's disease, starting from the diagnosis itself. And then in terms of management, we know that the shortcomings of traditional pharmacotherapy. And what pharmacotherapy do we have with us, which is relatively easily available, possibly the only one that's used widely in our country is still ketoconazole. And we know the efficacy is variable, and there is definite phenomenon, sort of an escape phenomenon, whereby the disease may initially seem to be under control, but soon after a few months, the efficacy tends to reduce. And then the side effects. One of the most important limiting factors to continued use of ketoconazole is the hepatotoxicity. And then even if you had metirapone, you are with potential side effects, hypokalemia, hyperandrogenism, even with the SS2/5 agonist like pasireotide, hyperglycemia is an issue. Then radiotherapy, we all know that it is a slow onset of action. And even before you see the advantage, the positive effect, quite often you may get the patient to land up in hypopituitarism. We do not know exactly when, so it requires much closer follow-up. And surgery. Again, many of the tumors in Cushing's disease, the pituitary tumors, small tumors, microadenomas, so theoretically it sounds that they should be very well amenable to surgery, easily taken out, and the disease is cured. Unfortunately, it is not so in the real world. Even first surgery success rate is not very high. And definitely, if there is a failure of the first surgery, subsequent repeat surgery, the remission rates are much lower. Pari passu, while understanding all these limitations, there has been advances in molecular understanding of molecular pathogenesis of the corticotropinomas. And these are identification of key somatic driver mutations, USP8 mutations, ubiquitin specific protease 8 mutations, BRAF mutations. In fact, USP8 mutations are possibly the most common somatic mutation in corticotropinoma in Cushing's disease, accounting for maybe 30, 40, 50% of cases. And in the ones who do not have ESP8 mutation, BRAF mutations may be found in up to 30% of cases. So maybe 50 and 30 together, maybe 80% of cases may have USP8 and BRAF mutations. And remember, these USP8 BRAF mutations are almost exclusive to the corticotropinoma. They are not seen in somatotropinoma or prolactinoma. And then beyond these, we have the understanding of the pathways of the development of the disease involving the epidermal growth factor, EGFR, the cyclin-dependent kinases, CDK2 in particular, heat shock protein 90. All of these, understanding their role in the pathogenesis, has now allowed us to use more targeted therapy towards the tumor, the positive pituitary tumor. So if we look at the newer treatment modalities, we could broadly divide, as in the past, as drugs that are acting at the pituitary level, that is tumor directed, or drugs which are acting at the level of hypothalamus or at the level of adrenal gland or even at the peripheral tissues. So if we look at the pituitary tumor-directed treatment, we were talking epidermal growth factor receptor inhibitors. So there are a number of inhibitors, geftinib and lapatinib, which have been shown to reduce, on the one hand, the tumor cell proliferation, so reduce the size of the tumor, reduce POMC expression, which is, of course, the precursor to ACTH expression. So a reduction of ACTH happens, and so reduction of cortisol happens. And then USP8 inhibitors, those can also, USP8 in a way, so what happens is USP8, the mutations, they tend to make the protease activity more stable. And this protease activity causes de-ubiquitination of the epidermal growth factor receptor. And if you remove the ubiquitin residue from the EGFR, then that becomes more stable, that is more resistant to degradation, and therefore it tends to, through subsequent intracellular signaling, it tends on the one hand to cause the cell to proliferate, on the other hand to cause POMC activation and ACTH secretion. So you can also use USP8 inhibitors. Then, of course, pasireotide, we already have, maybe not so freely, not in our country, but that's an approved medication elsewhere. And BRAF, as we mentioned, BRAF mutations, especially the V600E mutation, which, however, in other parts of the body are associated with highly aggressive tumors, melanoma, colorectal carcinoma, and so on. However, it does not mean the BRAF mutated corticotropinoma is a big aggressive tumor. They are generally the usual small microadenoma type tumors that we see in the pituitary level. But now you can use BRAF inhibitors, which can block the hyperactive MAP kinase signaling. And MAP kinase subsequently drives POMC expression. On the other hand, if we look at the right side, so right, we have cyclin-dependent kinase, which you can block, which blocks the cell cycle, and therefore it blocks the tumor growth. You can have histone deacetylase inhibitors. Histone deacetylases, we know, are related to activity of the DNA. So if you have a histone deacetylase inhibitors, they can be helpful in restoring the activity of tumor suppressor genes, therefore suppressing the tumors themselves. Isotretinoin, which is used otherwise in medicine, in dermatology, for example, even in hematology, it acts through RX ligands and can directly lead to repression of POMC at the pituitary level. And this is also known to act at the adrenal level by blocking MC2, MCR2 receptors at the adrenal gland, and therefore can reduce the action of ACTH at the adrenal cortex level. Similarly, heat shock protein 90 inhibitors can also lead to restoration of the glucocorticoid feedback mechanism of the pituitary, thereby suppressing the ACTH release from the pituitary. So these are the potentials that are there. Now, in terms of slide, give me a moment. Right. And then, of course, we're going straight to the renal part. You can have the MC2R antagonists, which will block ACTH receptor or ACTH action. Then we have the adrenal steroidogenesis inhibitors, of which we shall talk a little bit about levoketoconazole, osilodrostat, which of course is approved abroad in US by US FDA, but not yet fully available to us, maybe available on a named patient basis, but is too costly for many of our patients to actually afford. And then peripheral glucocorticoid receptor modulators, we had mifepristone, but now we are talking about relacorilant, which is a non-steroidal, competitive, highly selective glucocorticoid receptor blocker. So if we look at, quickly summarize at what stage these various treatment entities are. If you look at the approved drugs on the left, the green ones approved by US FDA, levoketoconazole, osilodrostat, and pasireotide. Now, why do you need levoketoconazole? In what way is levoketoconazole better than the ketoconazole that we all use as an antifungal and also in treatment of Cushing's disease? Well, the levo isomer is more potent in blocking the adrenal steroidogenesis enzymes, the 7-hydroxylase, 11-beta hydroxylase enzymes. And it has a longer duration of action, so it is well amenable to be given twice a day, whereas ketoconazole may best be given twice a day, though we often use it twice a day as well. And the other limitation of ketoconazole is its hepatotoxicity. Now, what levoketoconazole has been found to do is because it is almost 12 times less potent than the dextro isomer of ketoconazole. in inhibiting cholesterol 7 hydroxylase, the enzyme that is involved in bile acid synthesis. So it has less effect in overall bile acid synthesis and metabolism, and therefore possibly it has less hepatotoxic side effects, which does not mean that it does not have any hepatotoxicity. It still has, but it is less. So these are the approved. And then there are, what are the ones already tested in humans? Relacorilant, the selective glucocorticoid receptor modulator, the EGFR inhibitors, geftinib, and gefitinib and lapatinib, and cyclin-dependent kinase 2 inhibitors, roscovertin, also known as the salicylib, and isotretinoin. These are the ones which have already been tested in humans, as well as for aggressive pituitary tumors causing Cushing's disease. Immunotherapy, usually combination of ipilimumab and nivolumab, has been already tried. And then the others are in experimental stage, whether we talk of BRAF inhibitor or USP8 inhibitor, heat shock protein 90 inhibitor, or ACTH receptor antagonists. These are still in experimental stage. So I think we will maybe wind up with Cushing's disease only this tonight, looking at some of the clinical trials and efficacy data. With ketoconazole, we have the Sonics and Logics trial, which have shown that more than 50% cases there is urinary free cortisol normalization. Adverse events are there, but they are definitely lower than seen with ketoconazole. With osilodrostat, we have the link 3 and link 4, which are phase 3 trials which have shown its efficacy. With relacorilant, we have only possibly yesterday publication of in Lancet Diabetes and Endocrinology, the GRACE study result. Previously, there were impressive phase 2 study data. Now we have phase 3 trial data published recently, again showing its efficacy in terms of blood pressure reduction, in terms of glucose improvement in patients of Cushing's disease. And I think we can stop here. We can, it's already nearing 9. Maybe we can talk about acromegaly on another day. It's been a wonderful occasion interacting with all of you. And I hope people in the younger generation at least take up these issues with their keenness. Thank you. I'll stop sharing now.
Thank you, sir, for navigating us through the beautifully through the new therapeutic options in endocrinology. Now the session is open for any questions from the audience. Dr. Basharaj, you can take it from here.
Yeah, I think we'll wait for a few questions, but Bansali sir, a lot of paradoxes I could see in your talks, but it's very enlightening talk. So probably I think what you made sure to highlight was that probably the window period to treat and how much to treat and take care, where to stop is I think probably what is more important until we get to the further layers of this whole complex topic of longevity. Your thoughts, sir?
I think when we talk about the longevity, means we are decelerate the aging. And to decelerate the aging, the physiological changes, which are usually adaptive, let them allow to happen and accept it. Only intervene if they are really have shown to be deficient, then it makes a sense. But I think the whole focus now is changing on, one is on insulin. So now the people are more talking about the insulin, hyperinsulinemia, insulin resistance. In fact, they are the one of the major inhibitor into the senescence. So whether it is a signaling, whether it is a cell senescence, whether it is a mitochondrial dysfunction, so almost most of the process of aging are basically facilitated by the. So I think that's a very important one has to understand. I talked about the somatopause, menopause, andropause, and even adrenopause. They do happen. They need only intervention. But if you intervene them in a right person at a right time, you always have improvement in a quality of life and your healthy lifespan increases. But if you treat for the making the hormone of the what you have at the age of 25, then you lose. Then you don't gain it much. And more so, lifestyle modification is very important for longevity that one should do. Beside that, the points which I mentioned, your sleep optimization and your stress management and all. So eventually, I think every process in the day-to-day life helps in maintaining your cellular life. That's why we say, what is life? Life is a hormone, and hormones are life. So I think that we should see in that perspective.
I think very well put, sir. Balance. We that's why the World Hormone Day talks about hormones, balance, and health. So probably we'll try to see how longevity or life can be added. Health per se terms probably looks at that. Shubhankar sir, wonderful deliberation. Thank you for this thing. And definitely, I think we have got a lot of slides there, so we'll definitely get you somewhere to not to miss those further slides on acromegaly and whatnot, what are there in the kitty. But definitely would love to hear that. Cushing's has been an enigma always. So probably with advent of these newer molecules, are we do we have more chances of remission with these new molecules? Is it a promising arena, or still we have got a long time to go, sir?
The way that I look at it, I think no, what we all hope that there'll be a cure with one drug. I think that's not going to happen with all these medicines. And the newer the medicine, the costlier it is. So those issues will still be there, but we need to know about the science that's advancing. And some of these are, especially the understanding of the molecular pathogenesis of the pituitary tumor that's causing Cushing's disease. Those are relatively newer understanding, and so it's exciting to see targeted therapy being developed.
Yeah, I think yes, sir. Very, what I would rather not getting the word, but probably what you put
Precisely.
right word, correct.
Precisely.
Precisely, you put it exactly. And yeah, I think should be so it's a great beginning for the first webinar series of our ex-presidents of ESI putting their heart out and trying to come out or slightly a little bit of delayed sessions. I would rather tell 8 to 9. So probably eat early. TRE is what already Anil sir has told, that probably you'll have to eat early and go to bed quickly to live longer and more sessions with our stalwarts. So probably yeah, we'll try to get these things done probably next series. But and with the bottoms of my heart, as the in charge of World of Wonder celebrations, I would like to thank both of you, Anil sir and Shubhankar sir, for having this perfect opening deliberations on the first session of the World of Monday webinar series. Thanks a lot, sir. Thank you, both of you, Anil
Thank
sir and
you.
Shubhankar sir.
Thank you,
Thank
Basu.
you,
And
thank you,
thank you,
thank you.
Kaushik
Pankaj,
sir. Thank you, Dr. Kaushik Biswas, for moderating
thank
it
you.
beautifully. Thank you, ESI, for giving us all of this an opportunity for a learning platform to be created to understand and try to learn from our stalwarts and seniors of endocrinology. And I think with this, any questions, you can reach out to me or any of us out here. So you can text us, you can email us, or just WhatsApp us. So we will try to get back to you and try to answer it. And thank you all for joining this late, and have a great weekend. Thank you. Good night.
Thank you.
Thank you.
Thank you,
Night.
sir. Thank you. Thank you. Thank you, sir. बशीर भाई ठीक गया सब कुछ?
यस सर, यस सर।
ऑल गुड।